Okay, let's unpack this. You know that feeling, right? Staring down a really complex medical topic, maybe hepatorenal syndrome, and it just feels
Oh,
overwhelming.
absolutely. Information overload is real.
Well, think of this deep dive as your focus shortcut. We're zeroing in on exactly what you need to get a grip on.
And what's really interesting with HRS is how understanding sort of one core problem, the liver failing,
Yeah.
helps make sense of all the kidney issues that follow. It connects the dots.
Exactly. So today, yeah, we're locked onto hepatorenal syndrome, HRS. We're working from your revision notes, essentially. And the mission is simple. Break it down. Make it digestible, memorable, high-yield stuff that actually sticks for your revision.
And just to frame it, getting HRS right is so important. If you're looking after patients with advanced liver disease, it's a major complication, and spotting it early, that really matters for outcomes.
Right. So what's the plan? We'll start in the basics.
Hmm?
What is HRS? Then look at where it comes from, the etiology, and who's most at risk.
Then the pathophysiology. We'll definitely cover the two types. That's key.
Absolutely. Then what else could it be? The differentials. We'll touch on how common it is, the epidemiology, though data's a bit tricky there.
Especially UK-specific data.
Then how patients present, what tests we do, including the official diagnostic criteria, and crucially, how we manage it.
Both medical treatments and the transplant options.
Yeah, and we can't ignore the prognosis and complications. Plus, we've got some mnemonics, some memory tips sprinkled in to help lock it all down.
Sounds good. I think a key thing for revision here is getting past just rote learning,
Mhm.
really understanding why the liver issue hits the kidneys.
Totally agree. Okay, let's lay that foundation. What exactly is hepatorenal syndrome?
Okay, so in essence, HRS is severe kidney dysfunction. But critically, it's potentially reversible. In the absolute key context, it happens in people with advanced liver disease. It's specifically an acute kidney injury without intrinsic kidney disease. The kidneys themselves look okay structurally.
Right, so the kidneys aren't like disease themselves, they're reacting to the failing liver.
Precisely. It's a known complication, a serious one, of end-stage liver disease. You see it with cirrhosis, definitely with DVIAs, the fluid buildup, and also acute liver failure.
And what usually pushes things over the edge?
Often, it's something that causes a drop in blood pressure. Could be an infection, maybe alcoholic hepatitis flare-up, or even a significant bleed. These act as triggers.
Okay, that makes sense. So the liver struggling sets off a chain reaction. What's the direct link to the kidneys, the etiology?
Well, the main driver is this widespread circulatory dysfunction. It all stems from the advanced liver disease. And this leads to vasoconstriction in the kidneys. The blood vessels tighten up.
So less blood gets through to the kidneys?
Exactly. Reduced renal perfusion,
Yeah.
reduced filtration. Now, the exact mechanisms, the molecular details, they're still being figured out. It's pretty complex.
Got it. Liver problems mess with circulation, kidneys get squeezed. So who should we be most worried about? Who's at high risk?
Okay, number one is established liver cirrhosis, especially if they've also got portal hypertension, that high pressure in the portal vein system.
Right.
Other big ones are bacterial infections, SBP, for instance, any significant gastrointestinal bleeding, and maybe surprisingly, overdoing it with diuretics.
Ah, the drugs used to manage the fluid can actually become a risk factor. Tricky balance.
It really is.
Okay, let's get into the mechanism then. The pathophysiology. How does this all actually happen?
Right. This is where it gets quite interesting physiologically.
Mm.
You've got this paradox. The body has widespread vasodilation systemically, but the kidneys vasoconstrict.
How does that work?
The main theory involves vasoactive mediators. Things like nitric oxide, perhaps, are released because of the liver disease, and they cause massive dilation of the blood vessels in the splanchnic circulation. That's the gut area.
Okay, so blood vessels supplying the digestive system relax and widen a lot.
Exactly. Huge splanchnic arterial vasodilation. This drops the overall systemic vascular resistance, so blood pressure falls. The body senses this underfilling, especially at the kidneys.
And tries to compensate.
Right. It activates the renin-angiotensin-aldosterone system, RAAS, the body's go-to system for raising blood pressure and holding onto fluid.
Okay.
But here's the problem. The kidneys constrict their own vessels in response to RAAS and sympathetic nervous system activation, and other mediators like endothelin-1 get involved too. But it's not enough to overcome the massive splanchnic steal of blood volume. In fact, this renal vasoconstriction becomes part of the problem, severely reducing kidney blood flow.
Wow. So the body's fix actually makes the kidney situation worse because the root cause, the splanchnic dilation, is just too massive, like fighting a fire with gasoline in one specific spot.
That's a really good analogy, actually. Yeah. And this whole process helps explain why we get the two types of HRS.
Ah, yes, the types. What's type 1?
Type 1 is the really acute, rapidly progressing form you see serum creatinine double or creatinine clearance have in less than 2 weeks. It's got a very poor prognosis, unfortunately.
Oh, okay. Sounds urgent. Any way to remember that?
We use this memory tip. Think type 1 equals terrible, timely decline. Emphasizes the speed and severity.
Got it. Type 1 equals terrible. Timely decline. Okay. What about type 2?
Type 2 is slower, more insidious. Kidney function declines, yes, but it's a gradual process. The prognosis is still poor, make no mistake, but survival tends to be longer than with type 1.
Right, a slower burn. Memory tip.
How about type 2? 2 steps slower, just highlighting that slower progression.
2 steps slower.
Okay.
Helpful. Now, super important point.
Yep.
Patient comes in, liver disease, kidney numbers are off. How do we know it's HRS and not something else? What are the differentials?
Critical question. You have to rule out other causes. Top of the list is prerenal azotemia. Maybe they're just dehydrated, or something else is reducing blood flow to the kidneys that isn't this specific HRS mechanism.
Okay.
Then there's acute tubular necrosis, ATN. That's actual damage to the kidney tubules themselves, often from toxins or ischemia.
So structural damage.
Yes. And you also need to think about intrinsic renal disease. Maybe they have underlying glomerulonephritis or diabetic nephropathy, something actually wrong with the kidney structure or filters. And finally, obstructive uropathy. Is there a blockage somewhere? Kidney stones, a tumor pressing on the ureters.
So it really is a diagnosis of exclusion. You've got to rule out dehydration, direct kidney damage, pre-existing kidney disease, and blockages.
Exactly. That's the process. Okay, so how common is this? Epidemiology, particularly in the UK.
Right. Do we have good numbers?
Honestly, precise UK incidence data is lacking. We don't have exact figures, but we absolutely know it's common in that population with advanced end-stage liver disease.
So frequent enough to be a major concern.
Definitely. Yeah. The estimates thrown around suggest maybe 35, even 40% of patients with end-stage liver disease and ascites will eventually develop HRS. It's significant.
Wow, okay. So what does it look like when a patient presents? What are the clinical features we'd see?
Often, the most obvious things are decreased urine output oliguria and signs of fluid retention getting worse, like more swelling in the legs or abdomen.
More edema, worsening ascites.
Yeah. Plus general symptoms like fatigue, maybe worsening jaundice, and just generally signs of their underlying liver getting worse. It often overlaps with a general picture of decompensated liver disease.
Okay. So how do we confirm it's HRS? What investigations seal the deal?
Well, it's a combination. Clinical picture is key, obviously. Then lab tests, renal function tests are central, looking at creatinine, urea, electrolytes. Imaging, usually a renal ultrasound, is vital.
Right, ultrasound?
Primarily to rule out those other causes we mentioned, obstruction or signs of chronic kidney disease. You're looking for structurally normal kidneys.
Right, but the real confirmation comes down to specific criteria, doesn't it?
Yes, there's a formal set of diagnostic criteria. You need first a diagnosis of cirrhosis with ascitins, then evidence of acute kidney injury, usually defined by a rise in creatinine. And here's a really crucial one. No improvement in kidney function after at least 2 days of stopping diuretics and giving intravenous albumin.
The albumin challenge, why is that so important?
It helps sort out simple volume depletion, that prerenal state, from true HRS. If the kidneys perk up with just fluid, it probably wasn't HRS.
Got it. What else?
Absence of shock is important. The patient shouldn't be in circulatory shock. Also, no current or recent use of nephrotoxic drugs, medications that can harm the kidneys.
Makes sense.
And finally, no signs of structural kidney injury. That means no significant proteinuria protein in the urine, no significant microhematuria blood in the urine under the microscope, and, as we said, that normal renal ultrasound.
So putting it all together, cirrhosis with ascites, AKI, doesn't get better with fluids, no shock, no kidney-harming drugs, and no evidence the kidney itself is damaged or blocked.
That's it. It hammers home that point. HRS is a diagnosis of exclusion. You rule everything else out. The underlying mechanism we think is happening, that splanchnic vasodilation causing systemic circulatory chaos, kicking off RAS in the sympathetic system, messing with cardiac output, releasing vasoconstrictors in the kidney that leads to this functional renal failure. not structural damage, initially at least.
Right, it's the plumbing and pressure dynamics, not faulty kidney parts. Okay, so we've diagnosed HRS. What can we actually do about it? Management.
Okay, management goals are basically threefold. Try to treat the underlying liver disease if possible, optimize their circulation, and improve blood flow to the kidneys.
And the main strategies.
Broadly, medical management, using drugs and fluids, and then considering liver transplantation, which is really the definitive cure.
But it sounds tough to manage day to day.
Oh, it's notoriously difficult. Liver transplant is the ideal long-term fix, but finding a donor, plus the patient need to be well enough for surgery, but those are major hurdles.
Okay, let's break down the medical side first. What drugs are we talking about?
The cornerstone, with the best evidence, is using vasopressin analogs. Terlipressin is the main one used.
How does that help?
It causes vasoconstriction, specifically in that splanchnic area we talked about. By clamping down those dilated gut vessels, it helps redirect blood flow, improve systemic pressure, and hopefully boost perfusion to the kidneys.
And it's usually given with something else.
Yes, always with albumin infusion, 20% albumin. Volume expansion is key alongside the vasoconstriction.
Are there risks with terlipressin?
Yes, you need to monitor carefully. It can cause issues like ischemic heart problems, arrhythmias, fluid overload because you're giving albumin, and even digital ischemia affecting fingers and toes.
Okay. What else medically? You mentioned TPS earlier.
Yeah, transjugular intrahepatic portosystemic shunt. TPS can help reduce portal hypertension and ascites. But it's risky in severe liver failure, so patient selection is critical. It might be used as a bridge, maybe, to keep someone going until transplant.
Requires careful thought then.
Yeah.
What about just general supportive care?
Absolutely vital. These patients need hospital admission, usually intensive monitoring of fluid balance, ins and outs. Treating any infection aggressively is paramount, stopping all nephrotoxic drugs, and stopping diuretics, as we said.
Any other vasoconstrictors sometimes used?
Noradrenaline can be used, often in an ICU setting. Midodrine, which is an oral drug, sometimes combined with octreotide. The experiences may be a bit more limited compared to terlipressin, but they are options.
And then the big one, liver transplant.
Yes. That offers the best chance for long-term survival, whether they responded to the terlipressin albumin or not. If someone's needed dialysis for a long time, say over 3 months, sometimes a combined kidney and liver transplant is considered.
What about dialysis itself, renal replacement therapy?
It can be necessary, absolutely, to support the patient, manage electrolytes, fluid overload, but it doesn't actually improve survival in HRS on its own. It's a support measure, really, a bridge to transplant or recovery, if that happens.
Okay, primarily supportive. So looking longer term, what's the outlook? Prognosis, and what are the main dangers, the complications?
Well, untreated HRS, the prognosis is grim. Very high mortality. We're talking median survival, possibly less than 2 weeks sometimes, especially for type 1.
That's incredibly sobering.
It is. Complications-wise, you get the progressive worsening of kidney function itself.
Yeah.
Type 2 can flip into type 1. And they're incredibly vulnerable to infection, serious bacterial infections like sepsis, SBP, spontaneous bacterial peritonitis, pneumonia. GI bleeding is also a risk.
So it's a sign of really advanced disease and brings a whole host of other life-threatening problems with it.
Exactly. But the flip side is transplantation. It dramatically changes the outlook. With a successful liver transplant, 5-year survival can get up towards 60%, a huge difference.
Really highlights the impact of transplant. Is there anything we can do to prevent HRS in vulnerable patients?
There's some evidence, yeah. Giving albumin early, especially to patients who develop SBP, seems to reduce the risk of them developing HRS.
Okay, proactive albumin and SBP. Anything else?
There's been research into drugs like pentoxifylline and the antibiotic norfloxacin for prevention in certain groups, but I think more research is probably needed to really confirm their role.
So focusing on managing the liver disease, treating infections promptly, and maybe using albumin strategically seem like the mainstays for prevention right now.
Pretty much, yes.
Okay, let's try and crystallize this. Quick recap. HRS is severe kidney failure due to advanced liver disease. Kidneys are structurally okay initially. It's driven by circulatory chaos, splanchnic vasodilation, causing renal vasoconstriction. Risk factors: cirrhosis, portal hypertension, infections, bleeds, maybe diuretics. 2 types. Type 1, fast, bad prognosis. Type 2, slower. Diagnosis needs specific criteria, ruling everything else out. Management: terlipressin plus albumin, supportive care. Ultimately, liver transplant is key. Prognosis is poor without transplant, much better with it. Big risks are worsening renal failure and infections.
That's a fantastic summary. Nails all the high-yield points. The core idea to hold on to is functional kidney failure because the liver is failing, not a kidney disease itself.
Right.
Okay, final thought then, for everyone listening and revising. Given all these interconnected factors, what's the one bit of the pathophysiology you think is most crucial to really get for understanding both diagnosis and management?
Ooh, good question. I have to say, really understanding the role of the splanchnic circulation, grasping why those vessels dilate so much, and the downstream consequences, the fall in systemic pressure, the RAAS activation, the renal vasoconstriction that explains so much. It explains why the diagnostic criteria focus on volume status and excluding other causes, and why the main medical therapy targets splanchnic vasoconstriction. If you get that bit, the rest makes a lot more sense.
Excellent point. Focus on that splanchnic vasodilation link. Hopefully this deep dive has helped clear things up on hepatorenal syndrome for you. If you want more support for your MSRA prep, definitely check out pastmsra.com and also freemsra.com. Loads of resources there. Keep up the focus revision you're getting there.